Hello, and welcome to A Doctor's Diary, practical medicine for everyday clinical life. In this video, we are discussing Lyme disease, one of the most common tick-borne infections in Europe, and an important condition to recognize early in everyday clinical practice. Lyme disease, also known as Lyme borreliosis, is caused by several species within the Borrelia Burgdorferi sensu lato complex. The most relevant human pathogenic species include Borrelia obzelii, Borrelia guarinii, Borrelia bavariensis, Borrelia burgdorferi sensu stricto, Borrelia mayonii, and Borrelia spielmanii. In Europe, most of these species are present, while in the United States, mainly Borrelia burgdorferi sensu stricto and Borrelia mayonii are found. The disease was named after Lyme, Connecticut, where clusters of arthritis cases following tick bites were first recognized. The causative organism itself was identified in 1981. Lyme disease is widely distributed across the Northern Hemisphere and represents the most common tick-borne infection in Europe. The risk of infection depends on regional tick density, the proportion of infected ticks, and human exposure. Transmission occurs through the bite of infected Ixodes ticks, most commonly Ixodes ricinus in Central Europe. The bacteria are initially located in the tick gut and migrate to the salivary glands during feeding. Transmission usually requires prolonged attachment, often several hours, making early tick removal an essential preventive measure. The incubation period varies depending on the manifestation. For Erythema migrans, the most common early manifestation, it typically ranges from 3 to 30 days, with a median of 7 to 10 days. Early neuroborreliosis usually develops weeks to months after infection, while late manifestations may occur months or even years later. Most infections remain asymptomatic. When clinical disease develops, the most commonly affected systems include the skin, nervous system, joints, and less frequently, the heart. Erythema migrans represents the most frequent manifestation and appears as an expanding, usually non-raised erythematous lesion of at least 5 centimeters in diameter. It spreads centrifugally and may show a central puncture mark. Multiple lesions may occur in early disseminated disease and can be associated with systemic symptoms such as fever, myalgia, arthralgia, or lymphadenopathy. Neurological involvement most commonly presents as early neuroborreliosis, typically occurring weeks to months after the tick bite. The classic presentation includes painful meningoradiculitis with nocturnal radicular pain and possible facial nerve palsy, also known as Banwarth syndrome. In children, meningitis or isolated facial palsy is more common. Late neuroborreliosis is rare and presents as slowly progressive central nervous system involvement with gait disturbance, spasticity, and bladder dysfunction. Lyme arthritis usually presents as intermittent or chronic monoarthritis or oligoarthritis, most commonly affecting large joints, particularly the knee. Cardiac involvement is uncommon, but may occur as conduction abnormalities such as atrioventricular block or, more rarely, perimyocarditis. Diagnosis is primarily clinical and supported by laboratory findings. Typical erythema migrans is diagnosed clinically and does not require laboratory confirmation. In other manifestations, a two-step serological approach is recommended, starting with ELISA, followed by confirmatory immunoblot, if positive or borderline. In suspected neuroborreliosis, paired serum and cerebrospinal fluid samples are required to demonstrate intrathecal antibody production. It is important to interpret serology in the clinical context, as antibodies may persist for years after previous infection, while early infection may still be seronegative. Treatment depends on the stage and manifestation. Early treatment usually results in rapid recovery and prevents late complications. Oral antibiotics such as doxycycline or amoxicillin are first-line therapies, with cefuroxime acetyl or azithromycin as alternatives. Intravenous antibiotics such as ceftriaxone, cefotaxime, or penicillin G are used for more severe manifestations, especially neurological or cardiac involvement. Treatment duration typically ranges from 10 to 30 days, depending on clinical presentation. Prevention remains essential, as no widely available vaccine exists in Europe. Protective clothing, use of repellents, careful skin inspection are key. Careful skin inspection after outdoor exposure and prompt tick removal are key preventive measures. Routine antibiotic prophylaxis after a tick bite is not recommended. Lyme disease is not transmitted from person to person. Early recognition remains the most important strategy. If you found this explanation helpful, consider following for more clear and practical medical content designed for everyday clinical practice. Medicine is learned from books, but real understanding comes from shared experience. Thank you for watching, and I'll see you in the next entry.